Y'all, we are coming at you with all the anesthesia-related content, especially the stuff that nobody wants to talk about
Ooh,
because it's about to get real.
about to get wild.
It's about to get wildly
Wildly authentic.
authentic. Check.
And we're back.
We are back officially. Take three for this episode.
Oh man, this one has definitely tried our collective patience.
Let's
You know
just
what?
say I'm in charge of the sound system. Bad idea.
I'm a good consult. I should start charging.
If anyone would like to take us on and help us manage this, that would be great.
Yeah, oh, that's a great idea.
We got a ways to go.
So here we go. We're going live, episode number 2. Super excited to bring some fun, relevant content your way that is exclusively anesthesia related.
The secrets of anesthesia. What no one talks about.
Yeah, and maybe after this episode, maybe you will not want to talk about it.
Right?
But we'll see. I'm really excited. There's a lot that I've learned by proximity that I'm really excited to dive into some of that today. I think the jitters that you get pre-surgery are real. That's a real emotion, and being able to get some of this stuff out of the way and understand a little more of how you can prepare is a good thing.
I am actually just coming off of being on call day. We were supposed to do this earlier, but I got a add-on emergency, and it's just kind of fun. I'm in the thick of anesthesia. It's what I do. But then when I talk to people about anesthesia, people are like, dude, it freaks me out. I don't know what I'm doing. I have so many questions. But then I feel like a lot of people also are afraid to ask some of those questions. We actually reached out over on Instagram, asked you guys what are some things you would like to hear from the anesthesia perspective, but I wanted Lance to kind of come at this from a non-anesthesia perspective and help us get into the minds, help me and other anesthesia providers get into the minds of the patient, like what you're thinking, what kind of questions do you have going into anesthesia? Because as we were discussing about this, it is something I do every day. Like, it is so normal to have patients come in, put them under anesthesia, recover them from anesthesia, and then move on to the next. You hate to say it, but our medical system has become a little bit of this like system where patients are just one of the many for the day. So I want us to really focus on what is really happening pre, during, post, and really get some insights and on those secrets of anesthesia, the things that nobody is talking about.
I don't think it's a bad thing necessarily that, and you mentioned just getting cases through and doing I think any job that you get into, you fall into some sort of routine. That's not necessarily a bad thing. But I think that surgery might be the one surgery that patient goes through in their entire lifetime. And so it's a very unique profession in that regard, because that might be the one interaction that person has, or that might be the one or the third epidural that mom has, and that is her only experience, right? And so with that regard, I think it's an interesting conversation.
So I want to know from you, what are some things that before you go get anesthesia, maybe even the things you're like too embarrassed to even ask me or even talk about?
Oh, man.
So what are some of the questions, some of those burning questions?
Burning questions. Okay. Here's a good one. So tell me, like, when you go in there, there's prep work and stuff that goes into getting ready, but the thing that I think is the burning question for many and myself, during my surgery, am I just sitting there like stark naked on the table? Like,
naked?
While you guys are doing your thing, or like,
I think that's a really good question. And I feel like that's something that very few people ever ask me as an anesthesia provider. We'll go over the health history, all the risk, your anesthesia history, all this stuff. But then no one ever asks, like, what's it going to be like when I'm on the table? So yes, but also it's really important to us to keep you dignified, to, keep you as modest as possible. So if it's appropriate, we're not going to have you just out on the table naked. Depending on where the procedure is, we're going to prep that area, whether like, let's say we're doing appendectomy, they will pull your gown up, but they're not just going to expose your breasts. Like, there's no reason to, because we're working on your stomach, right? So they'll pull your gown, they'll keep your breasts covered, and then maybe they'll put a blanket over your lower private parts, or they're only going to prep the area that needs to be prepped. But like, let's say you're getting an inguinal hernia repair down in the groin area. Yeah, that area will be exposed for them to clean and to prep. Or let's say you're getting a hysterectomy. Yeah, they're going to expose that area for it to prep. But prep only takes a few minutes. You're only exposed for a short period of time while they prep it. and then they actually cover you with a big drape, and then you're covered the rest of the time by a big drape. So it's not like you're just exposed the whole time, and then whatever area that needs to be open is open. So
Love it.
I would also say we see it every single day as medical providers. So it's not like,
You're desensitized.
what's the word? I am a little desensitized to it all.
So let's talk about, you mentioned kind of like chronological order, right? So
Yeah.
pre-surgery,
I am totally putting my hair up.
what is like, yeah, you put your hair up. Hey, get comfortable.
Oh, okay.
We got the, it's just a fireside chat, you know?
Okay.
Um,
It's been a long day.
So let's go pre-surgery. Tell me why in the instructions, why do they tell you that you can't eat anything?
Okay. NPO status. NPO means nothing by mouth. Don't eat or drink anything. So here's the thing. So when you get anesthesia is wonderful. And by the way, anesthesia is kind of a confusing topic because the actual medication that's putting you to sleep is just one of the many aspects of anesthesia. So we give you the medication that makes you sleepy, the sedative, the propofol is the most common one. It puts you to sleep, makes you comfy. It is going to relax all of your body, but that includes like your gastric system, your esophagus, and then we're oftentimes giving you a paralytic. Because for the surgery, you need to be paralyzed for those muscles can't move. So while the surgeon's cutting through your muscles, they aren't twitching. It's just making visualization better, everything. You need to be paralyzed. Because of that, we have little gastric sphincters. Yes, I know you're going to love that word. I can only imagine.
Sounds awesome.
I can only imagine what's going through your head right now. But we have little gastric sphincters that actually keep all of our stomach contents down in our stomach. That all relaxes. So everything in your stomach is just going to come right up back into your mouth. Then that puts you at risk. You know, your trachea and your esophagus is right next to each other. All that food content can go back down into your trachea where you breathe. Now you're at risk for aspiration and you don't want that in your lungs. So we make you go not eat or drink anything for 8 hours. There's actually different guidelines for different kinds of food, like whole foods, it's 8 hours. Water or clear liquids, it's actually only 2 hours. But we tend to just tell people 8 hours, or a lot of times we'll be like midnight the day before your surgery. Here's a little secret, a tip for y'all.
Ooh.
When you're scheduling your procedure, if you have the option, be the first case of the day. Like you have to get there super early, but that means you're only going to be NPO for a shorter period of time. My patients that have to wait till like 1 or 2 p.m. to get surgery and they've not eaten or drinking anything since like 6 a.m. or 4 a.m. or whenever they tell them, they're very like frustrated and grumpy. And you also have to think too,
Understandably so.
Yeah, if you're like the 6th procedure for the day, there's a good chance one of the procedures before you is going to go longer. So you just kind of got to go with it. People are like, why aren't they on time? I'm like, well, the person in front of you had a heart attack. So I don't really tell people that.
I don't think you're allowed to say that.
But that's the reality. Like stuff happens. You know, we have sick people that get anesthesia. So tip, get your procedure done in the morning, but you're going to come in. So nothing to eat or drink.
Can you request, like, is that something that you can request that you get your procedure done?
Yeah, it just, you may have to push it out further until they have a morning opening. You know, it's like scheduling for sure.
Interesting.
Yeah. If it's an elective procedure and you can schedule it out and you have options, do it first thing in the morning for sure.
So is there a one-size-fits-all approach to how you're prescribing anesthesia to any given person? Like you've mentioned it before, how you call it like a cocktail, right?
Yeah.
So is it like, do you give the same cocktail every time, like espresso martini to everybody? Or are we going like Red Bull vodkas? Or
well, so everyone's different. I always joke when I see my patients, I go in and see them, I interview them, and you go over their health history, make sure they're optimized for anesthesia, because first thing I'm going to do before I even consent someone, I'm going to make sure they're appropriate for anesthesia. But then I go in and I say, you know, I'm your anesthesia provider, your CRNA, go over everything. And then I'm like, okay, now I'll have like Versed or fentanyl in my pocket to give them a little cocktail. And I'll be like, okay, now I am the best bartender you will ever have, or the best mixologist, because I'm about to give you the best cocktail ever. But yes, I mix up some sick cocktails, but it's not just for anesthesia. So I'm actually thinking about your analgesia, your pain. And then I'm also thinking of antiemetics, which are type of medications to treat nausea and vomiting. Because those of you that have had a lot of anesthesia, probably at some point you have gotten sick from anesthesia. That is one of the downers to some of the anesthetics we give and make you sick. So yeah, I'm kind of giving different cocktails and everybody is different. I'm going to give a different anesthetic to a 35, 250-pound male than I am to a 120-pound female, and not just because of size. And then I'm also gonna give a different medication to a redhead versus, someone sick with heart disease.
When you say different, do you mean like instead of 5 mLs, you give 10
No,
mLs,
not
or
different
is it a
doses. Like, I
different?
could
It's a
give
different
different
mix.
medications altogether. Yeah. Yeah. So, for instance, smokers, the only benefit to smoking cigarettes is you are at lower risk for nausea and vomiting post anesthesia. That's a secret you didn't know.
Which leads us to our first commercial break for Camel
Oh
cigarettes.
my gosh, Marlboro.
Marlboro Reds.
Don't smoke, kids. No, but it's so true. It's really interesting. And then the other thing that's like super important for us to know is this is another secret. If you are a drug user, you need to tell your anesthesia provider what you use. We don't care. Like, I literally could care less. I don't go tell anybody. I don't go report you. But I need to know what you're using. That way I can give you appropriate anesthetic. And also I can know how to keep you alive. Because there are some medications that actually cause it to where if you were to have your blood pressure to drop, like meth, for instance, if you take meth and then your blood pressure drops, I will not be able to get your blood pressure to come up. The medications I would usually use just will not work without going into like the
Yikes.
science behind it. It will not work. And if you do not have blood pressure, the heart's ability to shoot blood to the rest of your body, you will have no oxygen to many of your organs, to your brain, and then you're at increased for a stroke and all these things. So you have to tell your anesthesia providers what you're taking and if you're taking it. It's our job to keep you safe. Anesthesia is as safe as it is today because of us, honestly, because we know how to take care of you. We know how to give you the good medications. It's not just a one size fit all. It's not like this protocol we use. But at the end of the day, we're kind of holding you over death a little bit, like keeping you asleep in this deep anesthetic so you can do surgery, which I think is kind of wild if you think about it. But there's a lot of question marks on the patient side because they're like, I'm just supposed to show up and put my hands in your life and not do anything. So that's why I feel like so many people are stressed because you just lose control of everything. And then you wake up and you're like, what the heck happened?
What would you credit the learning those mixtures? Is that what you studied in school or is that experience?
Both. And then I will also say not every anesthesia provider is equal. You have to be one that like wants to learn, that wants to do better, and like really have a passion to provide a good anesthetic for your patient. Like, here's a good example. You will find if you get 10 CRNAs in a room and you have them write down their anesthetic plan for a C-section, okay? More than likely, our answers will be like 80 to 90% similar, and we'll all have a little bit different as far as regularly give ketamine, regularly use Duromorph, regularly use fentanyl, regularly don't use any narcotics, regularly do tap blocks. So there's all these little things. So we are all, what's that phrase? It's kind of gross. Different ways to skin a cat. That's how it is with anesthesia.
Wow. In this context, I don't love it, but okay.
But there are multiple different ways to provide anesthesia. And I think that's what people need to realize with anesthesia providers. We're all very different, but our goal is to get you to have a good experience, pain-free, nausea-free. But then part of that is you communicating with us. What's your family history? Do you have nausea in the past? Do you react funny to local anesthetics? That's another thing. Fun fact, there are people that genetically metabolize anesthesia differently. Now, at the end of the day, it's not always going to be perfect. And I feel like the place that I see people complain about anesthesia the most is probably epidurals and OB.
Yeah.
You can get online, and I'm a little like, I get ticked off sometimes talking about this because I totally almost got canceled once because a group of doulas came after me on social media. Welcome to the life of social media. Sometimes it's not all wonderful, but they hate it that we give epidurals and provide anesthesia for laboring moms and all the things, which I think epidurals are just the most amazing thing when they work. Some people just don't have great experiences with them.
Yeah.
And okay, so let's talk about one of them. One of them is that bad post-dural puncture headache. Have you ever heard someone talk about, I got this epidural and after it, I got this horrible headache to where if I lay down, it goes away. If I sit up, it comes back. Well, what that actually is we actually went too far with our epidural needle and we punctured the dura layer, which separates the epidural space and the dura space, which is where all that CSF fluid is. So essentially, your fluid is leaking a little bit, giving you that bad headache because the CSF actually supports and cushions our meninges, our brain, and everything. So until that fluid builds back up, we're going to have that bad headache. Well, it could be a multitude of reasons why they got that. The biggest one I see is like when there's bad communication between the anesthesia provider and the patient,
Mm.
and that patient just can't sit still and they jump. And then when you jump and someone's got a big freaking needle in your back, guess what's going to happen?
Yikes.
Yeah. So it's going to the wrong place. So when I go into a patient, I like really try to create good rapport with my patient and make them feel really calm and trust me and just say, hey, listen, these are all the risks with your epidural. But if you and I work really well together, we can really reduce those risks and give you a good outcome. And then I say, communicate with us. If it's not working perfectly, if it's one sided, or if it's just not a perfect epidural, let us know. We'll come back. That's our job. And I also think I'm more sympathetic to them because I'm a mom and I've had multiple epidurals and I love my pain-free birth. Like births are so fun to me because I just like get to sit there and chill and enjoy it. And I don't have to like, you see these videos of women who are like, like just, I'm miserable. I'm like, you don't have to do that. It's like going to the dentist without getting anesthesia.
Watch out, here comes the doulas
I know.
again.
Come at me.
Let's take a step back. Again, if we're going like in chronological order leading up to surgery, let's go back to, I guess, anesthesia school. And can you explain to the people what makes a good anesthesia provider, specifically CRNA? You've mentioned a few things about like kind of like continuing education. You mentioned you did a mid-flight adjustment in the way that you were providing epidural medication. And that's really great for you. I think that makes you a great provider. But like, just if there was an umbrella, if there's a CRNA or an SRNA watching right now, like what makes a good provider in that regard?
Well, so from a patient perspective, it's going to be so hard to know. Like really, truly.
Yeah.
That is the tricky part about the medical world. Like, how do you know it's a good anesthesia provider? How do you know it's a good surgeon? How do you know it's a good nurse? Like, what would
Referral, I would say
say?
probably referrals, like somebody else had a good experience and so they referred that person to you. Or, I mean, and this is probably most obviously, your doctor refers you to that physician. So it's like, oh, you got knee pain, you should go see Dr. Knee Pain Guy because he's the best in the area.
I think the other hard thing is too, is like, it's not like you can request your anesthesia person unless like, a lot of times we will get requests for anesthesia, but it's usually people that work in the hospital and know us. And be like, hey, I want Sarah to do my anesthesia, or a family member. But at the end of the day, you're not going to know who to request. But I will say this would be my challenge to the people, the patients, to the patient specifically. You need to be your own advocate. Like I remember not too long ago, my parents were getting something done. And afterwards, like I was asking my mom about it and I was like, hey, so how was it? And she told me, I'm like, well, what did they say about that? Well, I didn't know. I'm like, well, you didn't ask any questions? And she's like, well, I didn't know what questions. They should have told me. That's their job. They should have known to tell me this stuff. And I'm like, okay, well, how about this? And then she's like, well, I don't know. They should have told me. And everything was kind of like, well, they should have. They're the medical providers. And I get it. In her mind, it's a big deal for her. It's like her one procedure. So she should have been educated before. She should have been told all the information. And then the doctor should have spent all the time after. And they should have given her good follow-up questions and all the things, right? But at the end of the day, that's not usually how it works. I wish we could do that more, sit down and really give that holistic experience to people, but it's not. You are one of many, many patients. I work at a small hospital and we're doing 15 cases. You know, you're just one in the line. So to all my people out there getting anesthesia, you have to be your own advocate.
But I mean, in our defense, those of us that aren't in the medical field, it is challenging when you're going into an environment like that, when the medical professional is telling you what they think. I mean, it's like, I don't have like questions on the ready just to like fire right back. I mean, that's what their job is.
Right.
So like, I think it's a bit of a two-way street. When you say something like be your own advocate, well, maybe that means having questions written down before you go in, like trying to think as best as you can about it, and then feeling the freedom when you are with that provider, whether it's anesthesia or your ortho or whatever the surgeon is, feeling the freedom to ask those questions that you've written down and ask more questions to that person.
Yeah.
Knowing full well they are in a hurry. They're trying to get to the next case because, I mean, time is money, literally.
And, the hospital's pushing on you for turnover time and all this
Yeah.
stuff. So I would say be your own advocate in that sense. Like, okay, what are things do I need to know for beginning my procedure? And you can look some of that stuff up. I recommend finding someone in the medical field to ask those questions. And then also stuff like, what's recovery going to be like? Like, truly, because I've got a story. You're going to love this one. So I know someone that got like an inguinal hernia repair done. Okay. So he got surgery for that. Procedure went great that he knows of. And, like a week later, I said, hey, and it's a family member. And I was like, hey, how did your procedure go? How are you feeling? How's your pain? How's your recovery? And he was like so embarrassed to kind of tell me. But then he finally told me, he's like, well, I don't know what to do because I'm really bruised in my crotch and my scrotum is huge.
Oh boy.
It's like huge and blank.
All right. Here we
And
go.
he's like, and it was embarrassing. And I'm like, what? It was super embarrassing to him, obviously. And like, so those are the things that happen sometimes after surgery with anesthesia that people are just too afraid. They're embarrassed to ask. But the funny thing, I'm like, well, I was like, do you know why that happens? And he's like, well, I called my doctor and asked, and he said that's just normal and that's just it'll be fine. I was like, well, let me tell you why that's normal and why that'll be fine is because they used insufflation, meaning they blew up his belly to do the procedure laparoscopically so they could see. And then at the end of that procedure, sometimes because it's a hernia repair, there's like a little hole inside of you. That gas that we use to blow your belly up, it can leak into your scrotum area during surgery. So then they actually have to squeeze the balls.
Oh boy. Okay.
You have to squeeze it to get the air back out before they close you up. So yeah, that's going to bruise you a little bit. But they never explained it to him. They just were like, it's normal to bruise. So that's the kind of stuff I'm like, I wish we would maybe educate our patients a little bit better. Like, hey, just so you know, we had to squeeze the crap out of your scrotum
What?
and you're going to be really bruised. But on the other token, sometimes we do educate you. You're just like high from the anesthesia.
Well, you're also very stressed too. I mean, like there's just, I mean, I know for me going into any of the procedures that I've been in, it's like, it's a very stressful time. And so when you're telling me about all of the risks, I'm not sitting there taking notes. I mean, they send you home with the papers and stuff that have risks or whatever. But I mean, yeah, I don't know.
Yeah. So when I say be your own advocate, like find people that you could talk to, ask questions, maybe write down a couple questions before you go. You don't want to have this whole long list because then people are like, wow, for real. But at the end of the day, when you ask like what makes a good anesthesia provider, for those of you that are providers or student residents, I think at the end of the day is really listening to the patient. First of all, understanding what they want. What are they desiring? Because there are some people that, like, for instance, like don't want narcotics.
Yeah.
Or there are some people that are, for whatever reason, like you might think a nerve block is the best, but they just don't want that. Or for some reason, they want anesthesia a certain way. And it is your job to be an advocate for the patient, give them the best anesthetic, to listen to them and to take care of them, make sure they feel very well taken care of. So always being a learner and always growing in that. And then also learn from experiences. My goal from the start, when I first see a patient, I'm already thinking about how my patient's going to wake up. They say putting a patient to sleep is like anyone can do that, but waking them up pain-free, nausea-free is an art. So I'm thinking from the very beginning, do they need scopolamine patches? Do they need Pepsid? Do they need Reglan? Do they need, I love like a good pre-op cocktail for ortho. I like gabapentin and Celebrex because those are all helping with pain. They're hitting different receptors. Clonidine, like the alpha-2 receptor. I love it. Presidex, like what can you do before to reduce the amount of narcotics use? Because the reality is, as patients, pain sucks, but also you're going to get nausea from all those pain medications and you're going to get constipation. So tip for you guys, think about constipation. So that's water intake, do lots of fiber, a stool softener. You don't necessarily need to do like Marilax.
Is that pre-op?
No, like
Post-op.
just have it ready for when you get home.
Oh.
You'll be able to use that.
If we're sticking with kind of the flow here, we're talking about pre-op, and I don't think that was like necessarily off track to talk about the provider thing because it's just
We
Yeah.
get distracted sometimes.
Being better, yeah, I don't know. I think there's always a quest to be better at what you want to do, right? We've mentioned different cocktail mixtures. We've mentioned like what we can do in preparation for surgery. Anything else pre-op that you can think of that is important for people to understand?
So I think a big thing is stress. I think stress is something that everyone's going to deal with on some sort of level.
Yeah.
Even if you're an anesthesia provider getting anesthesia, it's just the idea of going under and you lose control. Like you don't know, and then you just pray to God you wake up. That's scary, right?
Mhm.
So as a anesthesia provider, we are really trying to help reduce your stress levels overall. I create rapport with my patients. I often like to sit down when I'm talking to my patient. That alone just really helps ease the stress level of a patient. I ask them questions. I make sure they have all of their questions answered. And there are times like I can tell I'm talking too fast to my patients.
Mhm.
I find myself getting in the busyness of the morning and and they're like, huh. And finally I'm like, Sarah, slow down. Let them hear me and let them feel like I'm present and they're, you know what I'm saying? That affects patient's stress level.
Yeah.
So stress and then also medications. We give you medications to prevent stress. And then also when we get to the OR, I love to turn music on for the patient. What do you like? What do you want to fall asleep listening to? How are you feeling? You know, there are studies that show that like highly reduces your stress before anesthesia, which improves the outcome of your procedure.
So is there like a genre that is like the most played? I mean, like, or an artist? Like, I mean, are we like majority Beyonce fans, or is there a AC/DC, Kid
You know,
Rock?
believe it or not, people are stressed out. So, like, half the time they'll
They don't even care.
no, like sometimes we'll get like the most weirdest requests. And I'm like, I've heard of that. Like, my last patient was like, I want this like jazz artist.
Oh,
And I'm like, is that even on Spotify? I'm like, make it keep it happy. You
so
want to go to
yeah,
sleep
so
happy.
that's the going to sleep music. Then does the playlist change once the
Oh my
patient
gosh, yes.
cashes out?
That just depends on the surgeon.
But is the surgeon the one who determines the playlist?
Usually, although, like, I work with a surgeon or two, or like they're like, we don't care as long as it's not this. And then,
Is there a sound system in the OR?
really old ones where I work.
Like, what are you like
You know,
are you like plugging in an iPad
one
or
of the
what?
hospitals I work actually doesn't have any sound system.
Flow of thought either. You know what I mean?
Right.
It's just a tricky.
Don't mind us for putting more wood. Now let's really dive in deep. Let's talk about some of the things that nobody is talking about.
I feel like we've covered some good stuff. I remember when I got my knee surgery, the anesthesia guy, he made me do like the count back.
Did you do the countdown?
Yeah, like count or
Countdown.
whatever. So which is fine. I counted and then I fell asleep and then woke up and felt great. Is there any like I remember thinking when I was going back there because I was very nervous and they were like asking me things. They knew that you were a CRNA, so they were asking stuff about that, and I have no idea what
You
I
get so
said.
quiet when
I
you're
was
nervous.
I was admittedly very nervous. What are some of the things that people are saying when they're getting wheeled back there? Like, I mean, I can only imagine you just hear some wild stuff.
Like, some people cry. I would say most people are like more quiet, and some people are like teary eyed. My goal is to like get medication. I have this like, oh, it's really good drug. It's called Versed. I call it like a IV Xanax. I try to get that in as soon as I can because that just chills people out.
Sounds delicious.
It is. It's wonderful for them. And it chills them out. And then like they stop crying and then it makes them more comfortable. Like often like people will start telling me jokes or just like relax and be more giggly and more happy. It's
Oh, okay, jokes. Okay, so in any profession, I feel like there are repeat jokes that you make.
you are the
Like,
king of
over and over
dad
and over
jokes.
again, like whether you call them dad jokes or just like your little sign-offs, or if you have a job like mine where you give a lot of presentations, just the things that you say that people giggle at.
Yeah.
What are some of the ones that are said often in that anesthesia moment?
Like what are my
pre-op?
go-to quotes?
What's your
My
go-to
anesthesia quote?
funnies?
Okay, well, first of all, I don't often do the countdowns.
Okay.
Like every once in a while I'll get a patient it's usually like young boys. Like I had like this 14-year-old, he's like, can I do the countdown? I want to beat my dad. Like my dad's record is. And I'm like, yeah, for sure. And then I had this 400-pound dude was like, I'm going to beat you. You can't get me under. I'm like, okay, good luck. I don't ever lose. But
Undefeated.
But I often actually don't do the countdown because the way I do inductions. So I don't know if this is a secret, but a lot of times when you go to sleep, you might feel like a real intense burn in your IV. Some people call it spicy. That propofol can burn, but there's a little hack that another anesthesia provider taught me. If you give lidocaine first, it binds to certain receptors and it helps prevent that burn. But you have to wait. Like my timing has been about like a solid like 45 seconds before you can push that propofol. So what I actually do is I give propofol very slowly to start because I'm really trying to prevent that burn.
Hmm.
So people could probably count way higher with me than others because I am not just slamming propofol. You have some providers that are like, they aren't going to remember this. We don't care. Whoosh, and they just slam it in your IV and people are like, ah. I'm nice. I'm a nice anesthesia provider. So I don't ever do the countdown because they could probably count down way faster. But I totally have my things I say.
Okay.
My favorite, you come in like, yeah, no, I'm your DJ. What kind of music do you like? I'm sure all the OR staff is like, she is so annoying. And
Same joke every time.
yeah, same joke every time. And then I'll be like, getting ready, be like, okay, take a few deep breaths in the mask. This isn't gonna make you sleepy. It's just gonna fill your lungs. Now think of somewhere warm you're gonna go on vacation. Where would you go on your favorite vacation? Like I usually ask
nice.
all of
Happy
my patients.
thoughts.
Yeah.
Yeah.
Again, trying to reduce your stress levels. Then I'm always like, where would you go? Are you a beach person or do you like to climb mountains? And I'm all like, oh, you're gonna go to the beach, have a mimosa for me or whatever. And then as they're drifting off, I'll be like, okay, let me know when you're nice and asleep. And then everyone kind of gets quiet to see if they like get it.
I like that.
That's my thing. Let
It's a
me
good
know
one.
when you're nice and asleep. I would say 9 out of 10, they say okay. 9 out of 10 times, they're like, okay.
Like, yeah, no problem.
And then-
I'll let you know.
Yeah. And then one time they'll be like, well, how much? And then they're gone. So I'm like,
You remember that when you wake up?
no.
No.
But it is funny. I think you had asked before, can you influence what I'm thinking about when I go to sleep?
Yeah.
One of my coworkers the other day, she was getting a colonoscopy and she requested me to do her anesthesia. And so we're getting ready to put her off to sleep. And right before she went to sleep, someone whispered the name of one of her other coworkers in her ear, just totally messing with her. And so they did that to her and she woke up. She's like, you guys made me have dreams of him. And she was like going off like, oh, and it was really funny. But so I don't know if there's actually science to say we can influence what you're thinking about. But I do think there's something like if you go to sleep thinking about happy thoughts, like going on vacation or something, it's going to be way better than it's like watching a scary movie before you go to bed. If you watch a scary movie with horror films and stuff, you're probably going to have bad dreams. So
Maybe just
I don't know. So maybe some psychologist is watching this and like knows.
Before I go to sleep, just say surfing. Beach.
Yeah, no,
beach,
for real.
beach.
Like, where would you go? You'd be like, I would go to Peru and go surfing because they've got the longest break on blah, 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 blah.
Yeah, sounds great.
No, he loves to go surfing, which we're going to be surfing soon. Excited?
Oh, man. Very excited.
Okay. So, yes, I do think your thoughts can be influenced a little bit, but I don't know. That should be a good study. Like, how extensive could it be? Like, hypnosis, can we hypnotize you to not have any pain and nausea after too? Who knows?
I'm sure if that was a thing, they would have figured it out by now.
I know. I will say though that like this is something that I wish Eastern medicine and Western medicine would play nicer together. Because I do think there are some, we're so turned off to any other therapy that's not medical. But at the end of the day, so much of our medical world is about treating an issue that's already there rather than preventative and helping reduce the need for intervention. And I don't want to go down a rabbit hole because that could be all these conspiracies involved. But I do think at the end of the day, if you can work hard to take care of yourself, you will have to get anesthesia a lot less than if you don't.
Preventative medicine is probably
it's a big deal.
Or preventative care.
It's a big deal.
Is quite the rabbit hole.
I know it is. Okay. What are the questions?
Well, I mean, I think obviously probably anything that happens after we as the patient falls asleep. I mean, like we talked about like getting draped and stuff like that. I mean, that's obviously a concern of many people if you're going to be just, butt naked on the table. Obviously preserving the patient's dignity and things like that.
So after you go into the OR, we talked about, we hook you up to our monitors. We're getting your blood pressure and heart rate and everything. And then we put a mask on your face. That mask, unless you're a kid, it's not to put you to sleep. It's actually just to fill your lungs up with oxygen and pre-oxygenate you. And then after you go to sleep, after we give you those medications, it's like 10 minutes of intensive anesthesia is doing all things. We're intubating you. We're putting the breathing tube in. Maybe we have to put a central line, an arterial line, another IV, hook you up. We are doing all of the things to keep you really stable and safe. And then I'm giving you all of your medications up front, your antiemetics, depending what is going on with you. I might give you some more things, some more antibiotics or something like that. And then the OR staff is prepping you while the surgical techs are getting everything ready. And then
So it's like a flurry. Like when that person falls asleep, it's a crazy.
Yeah, like we'll have students come in and they're like kind of like, oh, how do I set out of the way? Because it's boom, 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 boom. We're all doing things. Anesthesia, like 90%. I feel like anesthesia gets this bad rap. Like we get this picture of, that picture of Bernie Sanders where he's like sitting like this.
Sitting under the blanket.
Yeah. No. The one I forget which inauguration
Trump's
was.
first inaugural address.
Where he's like in the midst and he's like sitting like this. I feel like that's like the picture people view of like anesthesia. We're just like sitting in the chair covered in a blanket on our phones doing Sudoku or like whatever it is. But it's like because we do most of our work in those like first 10 minutes. We're intubating, dropping central line, like I said, all the things, getting you really stable. And then we just kind of sit and we continue to do passes. IV fluid, how's the patient's face? Is it being smushed by the actual surgeons? That's the other thing. We drape you and the surgeons can't see anything. So they start throwing all over their cords and their tools. And I'm like, whoa, that's the patient's face. So I'm working really hard to like protect your face. I pat it. Some procedures we have to do a Trendelenburg where we actually put your head down. So you're literally upside down. A lot of female procedures like hysterectomies or whatever, we actually put your head down and your feet way in the air. So like organs fall out of the way for the procedure. And so then you're at risk for like fluid shift up to your head. So if you've ever woken up with a poofy face or like poofy eyes, that could be because of the position you were in. Then we'll like reduce fluid intake because we don't want a bunch of fluid shifting to your face. And then, but it's part of our sweep of sitting there. So I'm looking at my fluid intake. I'm looking at my face. Can I visualize the eyes and all the pressure points? And then I'm looking at my tidal volume and my heart rate and blood pressure. But I have probably 30 things I'm doing in just like this motion, just like a sweep. And then I go back to what I'm doing. And I do that every so often. And it's like we've been trained. That's what they teach in anesthesia school. It's like they call it the sweep. Like you're looking at all this stuff, we're good. You're looking at all this stuff, we're good. And then we have at the same time, we have all these the beeps, the heart rate. Anytime the blood pressure is a little off, it beeps at us. So like we also learn different beeps mean different things. I can tell if something's going wrong based on the beeping from my machines. So I feel like we have that image that we're just sitting there like Bernie Sanders, but we're still working. I promise.
So it's partially true.
No, it is true. Like we sit there with a book or we sit there and do Sudoku or whatever. And we're also charting. Like I have a facility I work at that's paper charting. We're doing paper charting too.
Yeah.
But yeah, we're definitely doing other stuff too, but we're still working while we do that.
So with that many in that OR, and you've rotated through several different ORs, you've worked at a bunch of different places. What is like it would seem to me, again, you talk about that the pre-operation flurry of all the things that are happening, right? Who is like the person is there like a captain of the ship, or is it just like, it seems like it could be a too many chief, not enough Indians kind of scenario, but what's the, like,
I feel like everyone knows
the show?
Everyone knows their place. It just depends. Obviously, nursing staff, they have their own roles.
Yeah.
The surgeon, I feel like probably surgeon gets the most credit for things because he's a big, shiny guy with the knife. But you have to give a lot of the credit to the nurses because they really run the show as far as they're setting everything up and it's this whole production. So think about like theater. You have a whole production team and then you have your main musician.
Yeah.
That's a surgeon. They get the spotlight because it's the specific skill, right? It's a much more education for a specific skill, but like the nursing staff will make or break, how it runs. And then the anesthesia is kind of like, we're the safety police. We keep things safe and we become in charge when there's an emergency, when something bad happens. We are the ones that are going to tell you we need to cancel this case now. This patient we need to stop. So my surgeon, they always consult me like, hey, do you want to cancel this case? Because they don't want to do a case that's going to put their patients at risk. We get started, induction goes bad and the patient responds poorly. It's
not good for everyone.
They're not like, you're doing this case no matter what. They're like, whatever you think.
Yeah.
So who's in charge? Everyone kind of just has their own role.
Yeah.
So just teamwork's a big thing. And I think that's another reason why I like working in smaller places because teamwork's really important. Also, patient care is super important.
Yeah.
Sometimes in people's minds, they think going to the bigger facilities is better because more, like more experience in the city, but also you're going to get probably better patient care at smaller facilities.
Yeah.
So
It's cool to see how that team functions like internally. I mean, that's
Yeah.
something that's, if
Yeah.
you're talking about like peering behind the curtain of like the secrets of what's going on. I mean, people don't see that when you guys, because there's a baseline of stress that's higher than most levels in a working environment because of what you're doing. But then if something goes wrong, that team has to function perfectly.
Yeah.
Like when a patient, when something goes south, whatever that may be, you guys have to actually, let's just talk about that. So like if there's, let's just say there's an outcome, it doesn't go wrong, or you have to cancel a case, or something bad is happening in the OR, how do you run that? Because it's got to be perfect.
Yeah.
It's got to be by the book.
So I will say, like, those are the scenarios where anesthesia takes over.
Yeah.
There could be a place where it's different, but again, every experience, anesthesia takes over. We run, whether it's a code, where it's a cardiac arrest code blue, like we run the code. That's actually brings me back to my first time ever wanting to get into anesthesia. I was a nursing student in the ICU. Who knows what I was doing? And all of a sudden, code blue. One of the patients, like 3 rooms down, went into cardiac arrest in the ICU. And I was just a nurse student. I think it might have been the first code blue I ever saw. And, all the lights start flashing and it's a flurry and everyone's rushing to this room. And of course, I'm a little bit like when I was an adrenaline junkie. So I wanted to see the action. I wanted to see everything. I wanted to learn as much as I could. So I run in there and I'll never forget it. This like chick, she was a baller. She comes walking in. And of course, in my mind, there's just this little student and she had on her OR garb and she had the OR gown that like flowed behind her and she had
Was
a
a doctor?
scrub cap. It was a CRNA. This CRNA came walking in and she would just took over. And it was like the most beautiful, like orchestrated symphony. It was you do this and you do this and you do this. Get me a thing, bring this crash cart, started compressions, intubated the patient, dropped a central line, did an arterial line, stabilized the patients. But yet, so it was like chaos, but it was like
Organized chaos.
beautiful.
Yeah.
Yeah. And I'll never forget, I was like, who is that? And they're like, well, that's CRNA, whatever. I'm like, I will be here one day. And it's just a really cool, inspiring story for myself to know I got to a place where like you are the most knowledgeable, skilled person for those scenarios.
Yeah.
So yeah, an emergency in the OR, anesthesia takes over because our goal is to stabilize you. So it's like airway, circulation. We want to make sure you have the best opportunity to recover. So whether it's bleeding from surgery or a heart attack or an embolism or whatever it is, immediately our goal is to oxygenate you and support those vital signs. So I'm going to be like, someone get a second IV. We're starting chest compressions. You work an arterial line. If I need to drop a central line, I am. If the patient's not intubating, we're intubating. We're working on, then it's always call for help, get more hands on board. But then also don't be in there if you don't know what you're doing because we don't want chaos. We want controlled chaos.
Yeah.
Okay, what are some questions you think people have that they wish they would have asked about like recovery, about post-op?
Are you asking me that? Because
Yeah, like for you, what are some questions you maybe
what do I wish I would have
like
asked?
will I pee my pants or
I will tell you this in the most general sense. I wish that this last knee surgery that I had, I wish I would have just asked questions, period.
You were so high though.
I know, but I'm just saying, I like leading up to it and after it in my post-op appointments, I wish I would have just asked more. But I mean, yeah, I don't know. I mean, you mentioned be your own advocate, but it's like just feeling the freedom to ask those questions. I don't know. So we've talked so far up to like, we've got into surgery. We've talked about playlists. We've talked about some pre-op stuff. So what is like the closer?
Like what does closing of anesthesia look like?
Yeah, like before you wake up, after the surgery's done, before you wake up, like what does that time period look like?
So, and it's funny because this is all just every patient so mundane. It's just another whatever, but it's good for
every patient's not mundane. You're special.
Yes, you are special.
Every patient's special. It's just sometimes the task can be.
Okay, so finishing up surgery. So if you were getting general anesthesia, let's say, and there's a good chance you were probably paralyzed then, or you have an airway device in. So you are under a deep anesthetic. You're on a deep layer of anesthesia. I can't just like turn my medications off and you're good. Like there's an art to that. Like I said earlier, everyone can put someone to sleep. Waking someone up is like an art.
Yeah.
So my goal when you wake up, I'm trying to make you not cough a lot. I'm trying to make you not be in a lot of pain. I'm trying to make you not have a lot of nausea. If you got a big belly surgery, I don't want you to be like retching because then it'll rip your sutures open. But there's so much that goes into it. So I can't just take the tube out. If you're someone that's a smoker, you have, a reactive airway, if you asthma, COPD, all those things, it's going to make it harder as you come out of anesthesia. Having a tube in your throat, it's going to make you cough. But
Mm.
when you cough, I can't oxygenate you and get you breathing. So I'm now thinking like multimodal anesthesia, like what can I give to kind of help suppress those things, but not make you asleep and not make you sedate. So it's very much of this, again, orchestrated, beautiful, like art.
Hmm.
And so the big thing, and some people are good at it and some people aren't. But the big thing is I'm trying to get you to breathe while you're still deep and asleep. And then I'm balancing your oxygen levels and your CO2 levels. And I'm doing that. So there is so much that goes into waking someone up that like the layperson just won't ever grasp. And I'll never forget the first time. Actually, it was like my first rotation as an SRNA. And I was watching the CRNA do this. And I was just like, I was so intimidated. And
Mm.
I'm someone like, I'm kind of like a bullheaded, confident person. And I was
You are?
like, right? I was so intimidated. I'm like, I have no idea what the heck she's doing. She's titrating her oxygen levels and she's trying to explain it as she's doing it. She's like, I don't want the CO2 to get higher than this. So I'm doing this and I'm increasing the respiratory rate. And then I'm doing this, I'm doing this. And I'm trying to write this down. And I'm like, what is she talking? It's so foreign. So there is so much that goes into that kind of stuff.
Yeah.
Because we're considering, again, like I said, the patient and how they're going to respond and this and this and this. So we're getting you to wake up. And then right before we leave the OR, we're going to take out that airway device and make sure you can oxygenate on your own. You can breathe on your own. And then from there, we're going to bring you to recovery. You will not remember that period of time. You are going to be asleep and groggy. I hand off a report to the nurse. I tell them all about you. I tell you about how your anesthetic went, what concerns I had. We talk about your blood loss. We talk about your fluid volume, your urine output. We talk about medications I gave you. And then they keep you in recovery for a period of time before they'll bring you to the floor. They are helping you transition out of anesthesia into that post-anesthesia time. So that's the time where we're really trying to focus on preventing any nausea and vomiting and pain medication. And what I did earlier is going to really affect that.
Mhm.
So that's why I think, like my PACU nurses might be watching this, but I think all my PACU nurses love me because I really try to pay attention to that kind of stuff. I'm given Oframev, I'm given Toradol, I'm given Finnegan if I can't, like I have all my little tools that I like if it is appropriate. And you have to realize too, some patients, if they have a history of psychosis, for instance, I'm not going to give some of the medications because of the family that those medications are. So it's not just like a one size fit all, kind of like we talked about.
Yeah.
So everything does change. But I'm helping you transition to that PACU. And then that's when people like you might kind of remember some of that. Everyone wakes up so differently.
Oh, yeah.
Yeah, so differently. Like without saying, because I know there's a lot of people that don't drink alcohol, but if you've ever been drunk, more than likely that's probably similar to how you would be coming out of anesthesia.
There's a correlation there.
Yeah. If you know how people say if you're a happy drunk, you're probably going to be happy when you come out of anesthesia, or if you're like mad and belligerent. Some people cry a lot. Some people just make really funny jokes. Have you ever seen those YouTube? What was the one kid? Like the YouTube videos of the kid who wakes up just saying all of the dirty jokes and his mom was like mortified. Did you see that video?
No.
I was like a 13-year-old and his mom was like, I have never heard him talk like this
Is
before.
it kind of like David after dentist, like that old
Wait, who's
video
that?
where he's like, I have 2 fingers.
Yeah,
Like-
totally. You just and the parents are always like, get their phones out, like, what? I think my favorite was, remember, did I ever show you the one of the husband when he woke up and he looks at the lady in the video and it was his wife and he was like, you're my wife? You're so hot. And he would not stop going on. And that's just the anesthesia. So why it makes some people act one way, but then there are people who just cry and who are emotional. So like you're going to act the way your body acts. I don't think there's any way to control that.
Yeah.
But just know it's okay. Like it's a safe space. We try to maintain your privacy. We'll pull the curtains if there's people around. We want you to wake up like in a very safe space. And some people say funny things. That's probably something people want to like, am I going to say something inappropriate when I'm going under anesthesia or in? You might, and that's okay. We don't hold it against you.
It's all patient confidentiality.
Patient confidentiality. I do joke. So a lot of times when we get colonoscopies or shorter anesthetics, like quick, I always call it the good anesthesia. My patients will come out of anesthesia because it's just it's a lighter anesthetic. They aren't doing all the narcotics and gas, so the bad side effects. They'll come out and they'll be like, "Wow, that was the best nap of my life." Because to start, they're going to get a colonoscopy. Like, nobody wants their butt poked with like a scope.
Safe assessment.
Yeah, like everyone's kind of embarrassed. So everyone's stressed out already. And then I will be honest, me walking into like a 6-year-old male, they're like, great, this is
You
wonderful.
be staring at my butt for the next
young
hour.
girl. And I'm always like, guys, I'm at the head of the bed. I can't see anything. I see the inside of you on the screen. But so they're so nervous to start anyways. They barely will talk in pre-op. And then post-op, they wake up and they're like, wow, that was the best nap of my life. Will you come home with me? And they're not being weird. And then I think maybe after they say it, they realize what it sounds like. They're like, can you give me more of that at home? And I'm like, well, no, Michael Jackson ruined it for all of us. I've always said, I'm like, wouldn't that be awesome if you could hire me to give you a good nap? I feel like that's a
Man,
thing we should.
It's a business for that.
I know. Unfortunately, it's illegal. Dang it.
I'm sure there is actually a business for that out there. It's just not legal.
Just not legal.
Yeah.
But all that to say, coming out of anesthesia, it's okay. It's a safe space. Yes, you'll probably say something that you wish you didn't, or that's funny. If your family members are not nice, they'll probably record you. But we don't record you or do any of that.
All right. So you said how people say like, oh, that was the best nap of my life, take you home or whatever. What are some other funny things that people say, like waking up, or even we've heard from friends, like just funny stories of you walk in the room and it's like, wow, I wasn't expecting that.
Oh my gosh, I get all sorts of funny things. I think some of the ones that stand out to me the most, this happened just last week. Some people don't believe me. So I go in, hi, my name's Sarah. I'm a certified registered nurse anesthetist. I'm going to be giving you your anesthesia today. Go over health history, I'm going to look at your chart, and I go through all the cardiac history, respiratory issues, blah, 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 blah. Prescription medications, drug allergies. Have you had anesthesia before? Any problems with your anesthesia? And obviously, I'm like going through each area. I go through it all. And they just kind of looking at me like this. Yeah, like answering. And this guy goes, so you're going to put me under? And I'm like, yeah. He's like, I didn't know females could do that. I was like,
get with the times, buddy.
Bum, 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 bum. Yes, unfortunately.
It's a bad thing to say pre-surgery. You could probably say it post-op.
I was like, yeah, unfortunately, we're a budget facility here, so we only have female anesthesia providers. But he just, he's never had a female before. And then I did have another. And then on the flip side, I had this really cute older lady. I walk in, same thing. I go through my whole spiel and she's like just kind of staring at me. She's like, so you're my anesthesia person? I'm like, yeah. And she's like, this is so cool. I've never had a female before.
Aww.
It was so sweet. So I do have some questions to start. I'm going to pick out a couple of my favorites.
Pick the good ones. Only pick the good ones.
Okay, this is an interesting question. Why do I get all of the pain medications for something like a bladder scope if I'm unconscious anyway? So I think the question is, like, why am I getting pain medications for a procedure, maybe a smaller procedure, if I'm asleep anyways? So I think that is a good topic to cover. So just because you're being sedated doesn't mean you don't feel pain. What was that one movie like back in the day where like,
oh,
do you know what I'm talking about?
Yep.
Where the guy got put to sleep, but he was just paralyzed. So he could feel the whole procedure. It's obviously so dramatic and not real. But Awake or something.
Awake, yeah.
The movie was about the guy was like.
I never saw it, but it was like a horror movie,
surgery.
Right? He could feel everything. He could see everything going on.
Paralyzed, so he couldn't move or talk. But anyways, that would never happen. There'd be so many signs and things going wrong that wouldn't allow that. But it's the idea, just because you are under anesthesia being sedated doesn't mean you don't feel pain. Because it's just like you get cut and a receptor sends a signal from that to your brain that something's wrong. So pain medications, we are actually giving you different medications that attach to different receptors to reduce those signals to your brain that you're in pain. So yes, we do need to give pain medications to help. So just because you're getting a low invasive procedure doesn't mean you're not going to feel pain, especially let's say You had to get an airway device put in. We might give a little bit of fentanyl to blunt that sympathetic response for coughing or for whatever. We may give you just a little bit of like Toradol or Ofemev, which is IV Tylenol, to help with, let's say the surgeon was like, well, this is a little bit of an aggressive bladder scope or whatever. Now, I will say if you are getting a ton of narcotics, probably was unneeded. And I will say there are some old school providers, again, we talked about earlier about like being unwilling to learn or change or do better, that are just kind of stuck in their ways and they do that, and it's probably not the best thing. So, yeah, there are different reasons why you may need a little bit, but you shouldn't need a lot. So if you are an anesthesia provider giving a lot of narcotics for a bladder scope, maybe rethink that. Don't need a lot.
Yeah, maybe you should rethink that. I was going to say that.
This is a good question, and this is like a secret, not a secret, but tips, and it's maybe be like a little this I could see being uncomfortable for a lot of young girls to talk about, is like if you go whenever your procedure is, if you're on your period and you're bleeding, that's like embarrassed. People don't like to talk about their period. It's dirty and yucky to them. I think it's something that we should feel way more comfortable talking about than we do, because let's be honest, we have to go through it. So it should be something we talk about.
We don't have to go. Well, yeah, I guess we do have to
Yeah,
go
we
through.
do, and you still need to talk about it because it's a good thing to talk about. So we're gonna do our best to keep you dignified, to make you feel comfortable. So just let us know when you get there. Be like, hey, just I am on my period still. So we'll let you keep a pad on, and we may have to like take it away depending on what procedure it is, like right before we start the procedure. But we put a pad underneath you. But again, we're gonna work to keep you dignified and not embarrass you, but just know that's such a normal thing for us to deal with. It's like if someone like pees their pants during anesthesia, like we've been giving you a lot of fluid. If you're wet, it's super simple. We just change the pad underneath you. Very normal. It's not like, oh, this person did that. It's like, that's just what happens when you are not in control of your bladder or if you're bleeding before. So I hope anyone that has ever felt embarrassed because of that, like that is very normal and that's okay. And just let your nurse know, and we will make sure you feel very comfortable through all that. Okay. This is a good one. So, how do you explain the difference between anesthesia providers to patients, including AAs? So, okay, for you, you come in, you get anesthesia. Do you care who's giving you anesthesia? Like what their credentials are? Do you ask them questions like, well, are you an AA? Like, do you even know? Do you even care? So I
Not
would,
necessarily.
yeah.
But
So,
if I had the option between like if like you walked into the room or like some like, 60-year-old man,
you want the hot chick? I get it. I get it. I feel you. So I think from a patient perspective, people don't care. I think at the end of the day, people want someone that's going to take good care of them,
Yeah.
that's going to listen to them, provide them the best anesthesia, and make them feel comfortable. But there are three main types of anesthesia providers. You have MDs, MDDOs, they've gone to medical school. You have CRNAs. They are nurses who have had to go to ICU, get ICU experience in critical care, and have gone to a 3 to 4 year program for specialized in anesthesia. What once was a master's program is now a doctorate program. And then you have AAs. AAs are like they can be anything. Get your prereqs. I think it's a 3 year program, and then be an anesthesiologist assistant. They have to work directly with anesthesiologists and can never be autonomous. I think the biggest difference, sometimes people want to compare CRNAs to AAs. I'm biased. I'm a CRNA. But I think the biggest difference is CRNAs practice autonomously. Like at my hospital, there are no anesthesiologists and there are no AAs, just CRNAs. And we practice with just the surgeon. So AAs could never do that. And I do not believe AAs have like the same type of training as far as OB, cardiac, there are different things. So I'm not an expert in that. I don't really care. If you're an AA and you provide good anesthesia, then good for you. It's a good career as far as you get paid well.
Yeah.
I love anesthesia, so anesthesia is super cool. So yay for you. But I think at the end of the day, people don't care too much from a patient perspective unless you have a reason to, unless you have like a family member that's an MD or AA or CRNA. You probably know more about it because you hear people talking about it. So at the end of the day, be the best anesthesia provider, no matter who you are or what your background is. And it's all about job preservation. If you're an MD, you're going to think that's the best. If you're a CRNA, you're going to think that's the best. If you're an AA, you're going to think that's the best,
Sure.
whatever. Good for you. Do a good job. Okay. This one, Do you pop pimples when your patient is asleep?
That's disgusting. Yeah, it's gross.
I wish I could pop everyone's pimples.
It's so gross.
You shouldn't. You shouldn't mess with people. You shouldn't do stuff to people that they don't ask you to. It's like the same thing we did. I was doing a procedure the other day, and this patient had a hair about this long, just like growing out of their breast, not on their nipple. It was like the most random. It wasn't an ingrown. It was just a hair. And I so bad wanted to pick it. So I asked the surgeon, I'm like, can you pick that for us? Like, it's driving us nuts. And it wasn't like the person was unkept. It was so random. And so, but no, we're not up there picking your pimples. I wish we could, because I am
Maybe they left that there to like test to see if
test you.
you guys would pass the test.
That's another random thing. This is secrets of anesthesia tips. If you have fake eyelashes, like I love a good fake eyelash, I probably would take mine off before anesthesia. But if you have fake eyelashes, just let them know. Some guy providers just aren't very thoughtful about it. Sorry, guys. I'm totally throwing you under the bus. I feel like us girl providers are a little more thoughtful about fake eyelashes. Just ask them to use a little 2x2 or 4x4 gauze. Put the gauze over the eyes and then tape the gauze. And then the tape never hits the eyelashes. There's a tip for you.
Wow.
Oh, yeah.
The more you know.
Tip, the more you know. Who is better at intubating, MDs or CRNAs? Again, this kind of goes back to that, like, this is what I tell people. If you're going to be one that requests, this goes back to, it shouldn't matter what the credentials are. What you want is whoever is going to provide you the best anesthesia. So this is what I tell people. When you go to get an epidural, my mamas, you want the provider who gives epidurals every single day, all day long. So if that's the MD, great. If that's the CRNA, that's who I would choose. The reality is, from training in every type of facility, level 1, big female centers, trauma hospitals, everything, it's oftentimes the CRNAs that are doing a lot of the heavy lifting. The MDs often work as like the managers and the pre-op, overseeing a lot of the patients. Now, some facilities, that's not true. So I don't want to like piss anyone off, because everywhere it is different. But oftentimes it is the CRNA. Same way with intubating. When I was in school, when I would have an MD train me, I could just tell they didn't intubate very often, because they weren't, like, you could just tell they're rusty. I saw more teeth broken, more lips cut with MDs. Like, and I'm not trying to like pick on anyone, but then I would have like, and it's usually like the younger MDs, they wanted to keep their skills up, so they were really good. It was like the older MDs, I'm like, I remember one time and he's like been practicing for like 100 years. And I was warned, he's like, he'll feel you up, so be careful. He's like, just whatever. He like wanted to show off his skills to me as this female SRNA. And he was so bad. And he totally like yanked his blade on the teeth. And I was like, ooh, watch the teeth. And as a student, that's just like a big no-no. You don't ever like correct like your teacher. And on top of that, he like the MD that had been there forever.
Yikes.
But he was so bad, all that to say though, you want to learn from the people with the most experience, whether it's, and then you want your provider to be someone that has the most experience. Okay. So going back to the questions. Okay. Mac or Miller, girl. This is for my anesthesia people. You'll have no idea. So when we intubate you, we use a blade. It looks like, like the Grim Reaper blade, the big whatever, Sith, whatever. So when we intubate you, we use a blade. It's got a big handle, and there's 2 types of blades. There's one that's curved and there's one that's straight. I am very appreciative of my training. I had a provider at one of the facilities, an MD, who taught me so much, but I remember he would make me intubate with one blade 1 month at a time. So I had to go a whole month with one blade, and then I had to switch and go a whole another month. And it made me to where I am still very good at any blade. My tool, I say an anesthesia provider should be able to use any tool they are given. And that's how I was trained, to be very good with things. So whatever's most appropriate. If I have someone without teeth, the dentures, I'm going to use a Mac blade because it's got that nice round curvature, going to get the tongue out of the way. If I have someone with a really narrow airway, like hard to get my blade in, I'm going to use a Miller, because I can just going to pop it in there, get the uvula out of the way, and intubate. It just depends. But I will say, this is like for all my anesthesia people out there, as a student, they probably like shame you for wanting to use the glide scope, which glide scope's super cool. It's a blade, but it's got a camera on it.
Oh.
So I actually am not like I put the blade in the mouth and I'm actually watching. It's like a video game. I'm watching the screen as I'm putting the tube in the vocal cords. I immediately go to the glide scope if I have any reason to think it's going to be a difficult airway, because at the end of the day, it's not about me and my skills. It's about the patient, reducing the risk of trauma to the airway, reducing the risk of cutting the lips or breaking the teeth or anything. And every time I jab a tube in the mouth and I miss, I'm traumatizing the airway. I'm increasing the stress response to the body. So if I ever think, and I'm like, no, Hera, some people are like, I tried this and I tried this and I tried the bougie and then I tried this and I tried this and then I got it with this. And it's just like, you should have started with the glide scope. So choose your tools based on what's going to get you the fastest results with the least amount of trauma to your patient. So I'm a whatever it takes kind of girl. But
Did you say try to bougie?
bougie.
There's a thing called
a bougie.
There's
Yeah,
a thing
it's
called
really
a
cool.
bougie.
It's like this big, long, I'm trying to, again, use non-medical terms. So think of it as like a little stiff, but soft, rubbery end where it's like literally just a long stick,
Okay.
but it's very like flexible. So if I'm having a hard time with an airway, different people's airways are like anterior, just like on your structure, like you have no airway or no jawline. So usually with my blade, I can you're laying back like this. And so I'm up at the head of your bed and I put the blade in and I kind of scoop up your tongue and I pull like this part of your airway up. And usually when I do that, I can get to where I can see your vocal cords. They pop open and the vocal cords are hidden behind your uvula. What do you call it? The ding dong?
Yeah.
So that's what I'm aiming for. I'm trying to put my breathing tube in there. Well, a lot of times that vocal cords are very interior. They're hidden up further. So even with any of my airway devices, I cannot see that. I can't visualize it. And so let's say like you don't have a glide scope or you don't have a camera where you can see, you have this, it's called a bougie. It's like this big, long stick, flexible stick. And I actually will put my breathing tube on it. And then I use the tube and I'm with my blade, I have it open and I'm trying to get to what I think is my trachea. So you have two holes. You have your trachea and you have your esophagus. So if you put the airway device in your esophagus, you're not going to oxygenate because you're in the esophagus, right?
Mm-hmm.
So if you use that bougie and you kind of like feel what you think is the right place, because you can't visualize it like you usually do.
Yeah.
If you run it down, you can actually feel the clicks of the trachea. Click, 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 click. But if you're in the esophagus, you will not feel that. So now you can't visualize. You don't have a glide scope. You got to get the airway. You use the bougie. So you're a click, click, click. And then you're like, yes, I'm in the trachea. And then you run the breathing tube over the bougie into the vocal cords. So
Interesting.
it's a way to get an airway device by feel rather than visualization.
Yeah.
But again, like glide scopes have like made bougies like
Almost
obsolete. I mean, I shouldn't say that. Like trauma, they probably use them a little bit more or whatever. Yeah. But like if the mouth is full of blood or secretions and you can't visualize and you need to go by feel. But at that point, you're probably just getting a crike. So anyways, I digress. This is for the people, not the anesthesia providers.
For the bougie people out there.
For the people.
A lot of fun questions. A couple inappropriate questions. But what would medical talk be without something inappropriate?
Give the people what they want.
Especially you desensitized a lot. Just uncontrollable. I know I had a lot to say because of my anesthesia experience, but no, I'm just kidding. I think it's really cool to hear all the stuff that you guys go through and to try to understand it from a patient perspective.
Right.
I think it's something that the patient is largely uninformed of, is that experience when you do go out and just trying to see behind the curtain a little bit of what's going on. Yeah.
So drop a comment below. Let us know any burning questions you have I've done, multiple like day in the life videos where I just try to show a little bit behind the scenes. There's not a lot we can show because of patient confidentiality. And just knowing that like we can't show a lot of that. But I love just being able to connect with people from all over, answering questions like, what procedure are you about to get? Any tips I may possibly give you. We really appreciate you guys being here. Thank you for taking the time to listen to our Wildly Authentic podcast.
We hope you enjoy it. If you are enjoying it, give us a follow, smash that like button. Smash. And let us know if there's anything else that you'd like us to talk about. We have a really great lineup of things that are coming up, and we're so excited. And so until next time.
Peace out, my peeps.
The Wildly Authentic podcast.
We're real.
We're wild.
And we're wildly authentic.